Assalamu alaikum, Dr. Arif. You are live. We are looking at you.
Alaikum assalam wa rahmatullahi wa barakatuh. Good morning, everyone. First of all, thank you very much for GIS to giving us this wonderful opportunity again to participate with you and be part of this successful event. It's really amazing to see this meeting taking its place, and with all the respect to the members and the faculties and the leadership in this organization. So we have to introduce our team here, but I don't know whether I should mention really name by name. I have something like 20 people or 15 people. I don't know. It's getting less in Europe, and in our teams, getting more and more, Ahmed. So anyway, we have Dr. Ahmed, as you mentioned, and the rest, Dr. Wael, Hiba, Ruwaida, Priyesh, Walid, Ali, Dr. Maro, Anesthesia, and Rishma. And then we have quite good number. Mrs. Fadwa, she will be upset I didn't mention her name. So anyway, make it, it's a wonderful day today when we have a very exciting case actually, and with some exciting technology as well, what we are going to represent in our live case. Certainly, the issue is a bit to be keeping you in the loop. We have a critical patient on the table, and we may not be able to do everything according to our time schedule, because his pressure dropped once we crossed the wire to the LV. The pressure dropped, so you have just to keep this in mind. We are trying to maintain the pressure. It went down to 60 systolic, 70. So just that, and then I'll hand over immediately to the case presentation without any further ado. Dr. Luaya Budoka will do that. Please, go ahead, Luaya.
Yeah, good morning. So our patient for today is a 76 years old gentleman. His body mass index is 19. He's non-case of hypertension, type 2 diabetes mellitus. Unfortunately, he's a smoker. He presented to us with shortness of breath, dyspnea, NIA functional class 3, and he had also 3 attacks of dizzy spells and pre-syncope. He is also non-case of COPD and emphysema, and he is at home on bronchodilators and oxygen therapy. He has also a glaucoma, reduced hearing, and he has also hyperthyroidism. 5 years back, underwent diagnostic coronary angiography, revealed normal coronaries, and at that time he was asked to undergo TAVI, but he refused. His ECG, as you can see, next slide. Normal sinus rhythm with left ventricular hypertrophy and strain, and there is a PVC, premature ventricular contractions. Next slide.
Right bundle.
This is right bundle, yes.
Yes. Right bundle, yes. The ECG.
Left axis. Right bundle.
Go back to the ECG, please.
Right bundle and left axis. So
yes.
Bifascicular.
So next, the chest X-ray. As I told you, because of his COPD, you can see that there's increased bronchovascular markings. He has an emphysema. Next slide, please. These his blood tests. His hemoglobin is 11.5 gram per deciliters. Hematocrit is 34%. Platelets count 189,000. His creatinine is normal, 66. His urea is 3.7. And eGFR is 103. The glucose is 5.7 millimole per liter. His troponin is negative, 31. His home medication is aspirin, clopidogrel, gliclazide, pantoprazole, rosuvastatin, single pill combinations of sitagliptin and metformin, and he is in Lasix 20 milligram twice daily. Next. This is his echocardiography. As you can see, he has a calcified aortic valve, thickened leaflets. Chambers are normal in size. Next. This is the gradient across the aortic valve. The aortic valve area is 0.3, and the peak gradient is 184 millimeter of mercury. The mean is 118. There is a mild aortic regurg, and his right ventricular systolic pressure is about 45 millimeter of mercury. Next. These are the risk scores. When we talk about the ECC TVT, we do have 1.24. His Euro score is 7.2, and his Euro score 2 is 3.49%. Next.
So maybe, thank you, Dr. Luay. And we'll move to the CT analysis, and the CT report and will be represented also by Dr. Ahmed.
Next slide, please. Yes, a detailed analysis of the CT for this patient. As you can hear, we like to start with the bird's eye view, which gives you a complete appreciation of the sinuses, the size of those sinuses. And here, as you can see, the left ventricular flow outflow tract appears a little bit larger than the aortic annulus on different levels review. We have also mild calcification of the aortic valve, the left ventricular outflow tract, while the aortic valve itself is severely calcified, as you can appreciate here. And if you can see on the upper right corner still frame, there is asymmetrical distribution of the sinus of Valsalva, where here also you can see diffusion of the right and left coronary cusp on the right side and the larger non-coronary cusp on the left-hand side. This takes us to the diagnosis of a Siever's type 1 bicuspid aortic valve, as you can appreciate from the images. Next, please. So this is the calcification, takes us to the type 1 with the fusion of left and right coronary cusps. Next. So as we are dealing with a bicuspid aortic valve, we have several measures to see, starting with the usual annular measurements. The perimeter in this patient is 78. The area is 465. The diameters 21, the minimal diameter, which is important when we choose the balloon size, and the maximal is 28. And this gives us a perimeter area derived and the mean diameters of around 24 point something. LV outflow diameter is a little bit larger, as we saw, and the sinus of Valsalva are quite okay in terms of size. They are capacitant from 32, 34, and 34, with a large perimeter of exceeding 100, so it's 107. In terms of angulation of the aorta to the LV, it's not that much at 45. And we have an acceptable coronary heights, with the left being around 12 and the right being 17. If we, next slide, if we look to the supraannular measures, where as we are dealing with the bicuspid valve, the intercommissural distance, which we take 4 millimeters above the annular level, is 29, and the supraannular tracing has a perimeter of 77 and an area of 421. This takes us to the distribution of the classification of the flare type, where we have the annulus is the smaller part and the intercommissural distance is the larger part, and this puts us into the sizing stage at the annular level. So we'll size based on the annulus in this patient. Also, I like to grab your attention to the calcium of the patient who is having a very severe calcification, calcium score for the aortic valve exceeding 2,300, which puts us in the category of severe, very severe calcification. Next. These are the usual angles that is given by the analysis, the coplanar view and the cusp overlap view, which we are going to use during implantation of the valve. Next. Yeah, the periphery of the patient are quite acceptable, no calcification, mild tortuosities, so it gives us no problems during accessing the both femorals. Next. So the strategy of our heart team is to have a right femoral access. All our LCs are ultrasound guided. Conscious sedation up till a certain point, and then we transfer to general anesthesia. We use the carotid protection using a Sentinel device, and we will do TAVI using Evolute Pro Plus 29 with the from the right side, and we will finally close with a Manta device. Next. Okay.
So thank you very much, Dr. Ahmed. And back to the panels and chairman, Mr. Chairman. I mean, we have really quite a hot topic here. There are a lot of questions probably to be raised. about the sizing, about the device for pacing, about the access, if you wish to. We have some challenges. This patient has been reluctant to do surgery 5 years ago that he has been offered. So this is a case where usually, according to the criteria, goes to surgery, but because of the age and because of the comorbidities, and the patients also wish, this has been taken as a high-risk TAVI patient for today. So at present, I have, before I come back to you, I have a 6-French sheath on the right radial side. We have the right femoral axis, left for the pigtail, and the SAVI wire, which will be explained in a while after we go back to you and hear from you your comments and your panels, and then we will start. Please, go ahead, Ahmed.
Very nicely demonstrated, Dr. Arif. And like always, Sharjah always start with the new toys in the region with the SAVI wires. That's very nice to see in the place. We are looking forward actually to see how is this wire being used by you. Dr. Belghaith, first question is for you. I have noticed since I came back, to be honest, that bicuspid is more of a problem in our region than in our region.
Sure. Actually, when we started the TAVI in 2010, we were not paying a lot of attention for the difference of the anatomy. And when we start, we used to have Dr. Ahmed Umran. He's one of the senior in the echo. And even if the CT scan did not concentrate well, he will tell us in the cath lab, this valve is bicuspid. And we noticed that the incidence of bicuspid valve, it's not very low. It is there. When you look at it, either you will find a typical bicuspid or maybe functional type of bicuspid. That's why I think this case we have to pay a lot of attention and do a good preparation for this anatomy. And I agree 100%. This is a typical TAVI patient. He's not surgical to me.
Thank you. Dr. Abdurrahman, question. Valve selection for this patient?
Yeah, but both valve technology, either self-expandable or balloon expandable, they work the same, give the same results, same hemodynamics. Once the valve size for the self-expandable is above the 26, or maybe is the larger is the better, and the balloon expandable 26 and more, the mismatch is low. But this particular patient with significant calcium bicuspid probably is a predilatation for both, for balloon expandable or self-expandable is needed. One is because of the calcium. The second is the area is too small. So is 0.3 is, and the gradient is high. They may face a hemodynamic instability even with the wire. So it's better to give them the positioning, especially for the self-expandable, because you need sometimes the positioning accurately in the bicuspid valve. If you are too high, it may bob up, or if low, it might drag the, though the LVOT area is good, is appropriate even for the self-expandable, it will land nicely.
Very nice. So, Dr. Arif, what did you do for valve selection here?
Well, as Dr. Abdurrahman said, this is a size that can be used either of whether it is balloon expandable or self-expandable. Both can do the job. And we have pro and cons in each device. I mean, the favorite of each center, the operator experience with each device plays a major role also. You feel comfortable with everyone. I don't think there is a major difference, frankly said, in this case particularly. Now, we have to move maybe forward. Thank you for the input. I mean, we have a lot, as I said, to discuss. The role of sentinel device or cerebral protection device in this case, that's also something to discuss in bicuspid valve. We know that the risk of the embolization, cerebral embolization is a bit, almost double. It's almost 2.5 compared to the with normal tricuspid valve, which is 1.6 something, or less than 1.6. Post-stroke. So that is something can be also discussed. Unfortunately, we don't have so far, again, randomized trial proving this, but that is a good topic to be discussed. Now, let me just, because we have to move forward here, I'll ask just Dr. Wael to explain about the SAVI wire because we will start pacing and advancing our balloon. That's also a topic to be discussed, but we have already selected a balloon, a crystal balloon, 20 size, because of the diameter. We have minus just one, as explained by Dr. Ahmed, and that's how we size the balloon for pre-dilatation. And we think that this kind of cases has to be prepared well. We know that the chance of popping up or popping out is high, especially if we are aiming to go for high positioning. We have a couple of things to worry about, but again, we have to be prepared. We have an AR grade 1 at least, and that is something predicting me that, or should show me that it might get worse after balloon, and we have to be ready with our device. So Dr. Wa'il, maybe you can explain the Savvy wire, if you don't mind.
Good morning, everyone. I'm really excited to present the Savvy wire. This is a new kid in the block in our TAVI cases. We just got it. We just got it recently. This wire is by Opsense, and it is a fiber optic second generation wire that comes in two sizes. One size is the extra small. You can go ahead. One size is the extra small that we are using today, and here's the sensors. This wire, first of all, you can get the like continuous pressure monitoring gradient during the whole procedure, and also you can pace nicely over the wire. The wire is really the sense of the wire. It's an extra port, but it comes between the Safari wire, harder than Safari wire, and less than the Convida or the LandQuest. It's really nice, and it gives you a very nice pressure, as you can see on the screen. If we can
Change the screen, please, to the pressure wire.
go the screen now.
Yes, please.
Hemodynamic.
Hemodynamics.
The panel is eager to see.
Yes. The other one, please.
The other ones are. Yes, this is pressure we got from the Savvy wire. And as you can see, we have a mean gradient of 100 on this patient. And you can also do a post implantation pressure gradient using it, but you need to equalize. We'll see, we'll do it today, inshallah, and we'll show you how to, it helps a lot.
Yeah, the presence of a transducer always in the LV is a great benefit during the...
So thank you very much, Dr. White. I think we are moving because, as I said, patients a bit, the anesthesia is pushing me to move because he's maintaining things with some inotropic support. So we have the balloon now, and we need to, if you want, we can just try pacing before we go in, please.
If you can focus in my hand, please, I want to show you guys the pacing. Now we have a pacing of 160.
So we have the alligator on one side, the crocodile cliff on the right side, which is placed in the left femoral vein.
Yes.
And then this is the other
If you,
electrode.
you have this area, you have two areas you can pace on. This area is the silver one and one at the end. And you keep your pacemaker on, and now just you connect. The pacemaker is on.
So, Dr. Arif, what size of balloon you used?
It's a 20, crystal 20 semi-compliant balloon.
This is what is the rate?
What, guys, Dr. Salim?
160.
So we can see it's pacing nicely, Ahmed. If you can see on the monitor, I'm going in now. Stop pacing, please.
Okay.
Off pacing. So
Nice.
just demonstrating,
Nicely
making
pacing,
sure
yeah.
that things are fine. We'll give a little time to recover, and then we will go with the balloon.
Dr. Salim, what size balloon you would use usually for pre-dilatation?
You know, so number one, you know, bicuspid is very challenging in terms of, you know,
Let's not go
sizing,
one
etc.
second.
So I think what they
Who's the
used is
please?
the ICD, you know, for sizing, and they used also the annular, and now they're using the balloon. They use a 20. I may use the 22 actually in this case. The good thing about the annulus is more circular, and that's not, you know, usually the bicuspid is more elliptical.
Dr. Faisal, now for this case, this patient already have a right bundle. And we have also left access.
We have some challenges.
We can take a smaller bundle.
Would you go for LV wire basing?
Actually, using the wire from the beginning with
Stop
this
basing it.
classification, usually it's not indicated because
Come on,
the patient definitely he will need to be on basing for a longer time, and we may need pacemaker. So I think the regular
Save that one,
lead,
please.
it will be better than
Can I have
using
another
this.
balloon? What, other
15
okay.
balloon, yes.
Can we have the 15, please? So, yeah, you have seen as Dr. Ahmed and the panels, we could not cross with a 20 balloon. It's quite tight, and we are expecting in the bicuspid valve to have some
But it
struggle
did not
with the
reach
crossing.
the valve. Probably if you partially inflate the balloon to 2 or to overcome the friction
We will
to
do
the
that.
curvature,
Please.
it might be appropriate.
Could be, we will try that again. We thought to go with a smaller balloon just to do something now.
Dr. Arif, you were happy about the crossing. You were crossing in a good area of the valve.
Yeah.
Okay.
This is smaller. What size?
15.
15, okay.
Tension on the wire. There is some tension in the wire. There is a lot of stress in that.
Yeah. Can you go with a 2, please? 2, inflate 2, just a little bit, please. Just a bit. Okay.
And deflate while advancing.
So, not too
And
much.
deflate while advancing.
Deflate.
And push.
Yeah, we are doing this.
And pull the wire a little bit.
Yeah, we
Pull
have
the
to-
wire.
With it.
We'll do again, please.
Okay.
Same, please,
But the
again.
problem-
One more time, and
Dr. Adil,
okay, down, please.
question is for you. Now, LB pacing, single access yesterday by Dr. Kabadia.
Okay.
No sedation.
Yes.
Okay.
How minimal we can go in
Negative,
TAVI?
please.
Negative.
What's the
Hold
question?
the wire. Hold the
How
wire,
minimal
hold
we
the
can
wire.
go for TAVI? Minimalistic approach for TAVI. They are doing LV pacing.
Yeah.
Yesterday we were talking about single
One
access
second, please. 1 second.
for TAVI and no sedation, no echo in the room.
1 second, please. I'm
I think,
crossing.
I think what they're doing is quite minimal. You've reduced your
Okay, let's, 1 second.
temporary
now, please.
pacemaker puncture.
Let's
But
do.
you're adding your
can
sentinel
we-
device,
Little bit,
whether that
little
is
bit,
needed
just
or
little
not.
bit.
Tolanda is controversy, but if you're going to use it in any patient, this would be the patient that you use it in.
Okay.
Dr. Arif, you
Save that
crossed
one,
very
please.
nis here.
Yeah. Okay, so let me reduce the tension.
What
There's a lot
size
of
across,
tension
Dr.
in the
Arif?
wire. 15, that is a 15. 1 second, please. Now, let me just go back a little bit. Can we pace, please? Can we pace, please? 180, yeah. Okay, Ahmed.
Nice.
Down, please. Oops, be careful, be careful, be careful.
Give me another
Connect, please.
another syringe. Another
It's
syringe.
possible. Stop facing.
We can go out.
Okay.
Go out.
All right. That's fine, that's fine. Just be careful of the wire.
So, Dr. Arif, in your hand, what does the wire feels? Is it more of a stiff or is it just like a safari?
It's like a safari, frankly said. The feeling I have I don't feel much difference, frankly said, between it and the safari.
That's good. Safari is a good wire.
So you need to...
So we're going to enlarge the balloon now? You're going to use a larger balloon?
Yeah, we'll take the 20. We'll take the 20 again.
The original balloon.
Yeah.
Ahmed, you are a fan of cerebral protection, Shehri.
Yes, Dr. Arif, if you can.
What
if you want,
cases
you
you
can
use
show the
cerebral
sentinel,
protection
the
for?
Vine,
We'll do... Just let me have the 20 balloon first, please. And we're ready with the valve here.
Okay.
yeah.
For
Can you show
the,
the sentinel?
for the cerebral
Dr. Ahmed,
protection,
Can we show you the sentinel?
if there is any patient that
during
we will improve or he will get
Hold on.
benefit out of all of the cases that we do is like this cases, high calcium score, bicuspid aortic valve, and with a heavy calcification at the leaflet. I think it's, well, if there is an evidence that it will come to be positive, it will be from these kind of patients. And about the crossing and inability to cross in the first, maybe sometimes that you enter the aorta at one of the orifices that is smaller. So if you take a pigtail or an end-hole catheter and then you adjust your wire in a way that to see that, to build it up, to get into a wider orifice.
Put the pigtail back, put the pigtail back, please. So you have seen that it was also some struggle again with a lot of tension when.
Yes.
Which balloon is this?
The 20.
This is the 20, sir.
The original
20.
balloon.
Okay. We are ready now. Go to the pigtail. No, still I need the pigtail in place, please. We can see that. It's okay, but I need to have. Yeah. No,
My
this is
balloon
the
seat
right
here.
Okay. Let it be there. No, this is not. But anyway, we will reposition that. Small test. Yeah, we need a wire probably. Okay, let's do
a position after the balloon.
Can we pace, please?
Okay, connect your minute. Okay, Dr. Arif.
1 second, please. So we need to have a good connection to the LV, so we have to advance. Okay, let's go, please, Ahmed. Look at that with
Nice, nice.
Down.
That's so satisfying looking at.
Stop pacing, please.
Too much calcium there.
Dr. Belghith, there is a very huge rafi between the right and left coronary cusp here.
You want to do one more time?
Yes. Would you be afraid of injuring the annulus or the sinuses here?
Let's go pacing. 1 second. Just let it recover a bit. Let's go one more pacing again, please.
Okay.
Pacing.
Balloon expandable valve.
Go.
I think we talk about this heavy calcification and bicuspid. You know, when we start, we were trying to avoid the balloon expandable and bicuspid, to be honest with you.
Okay.
But in the last few years, we have a good confidence that they can do the same job, maybe even the balloon expandable. If you prepare the patient very well with pre-dilatation and sizing, you will have a beautiful result. I agree that this anatomy is not good, but this is what you have. And those are the patient with this age, they need some intervention. But again, do it in systematic, very meticulous, take your time.
It has a EDP.
You will be okay.
Can we have the EDP? Can we have the EDP connection?
Okay, and now we are using the SavvyWire to see how much is the EDP. So our EDP did not increase a lot, indicating that we don't have a massive aortic regurg post dilatation.
Wire, you need the wire. You will not be able. I think better to use a wire.
Dr. Mugheri,
that's good.
For this patient, his coronaries height is not high, the left is not high.
Can we take the...
How do you think the left and right will behave in terms of, it's a curtain-like?
I think the sinus is huge, it's 32, so there is no, the risk is low from the coronary leaflet, inshallah.
Go to the
and in addition to that is a bicuspid. So the bicuspid usually depends on the line. Where is the maximum leaflets,
شلون الصورة في الكاسب overlap.
This is not
to the radius.
The cusp overlap.
Yeah, but this is not in the right
main. So it's not
check.
low, but it's reasonable to use whatever the valve use. Maybe safer with the self-expandable because the sinusoidal junction is very wide, it's dilated. So the flow to the coronaries is it's important. And with the balloon expandable, probably the valve will land below the level of the coronaries or at the level below the sinusoidal junction. So it's giving the good chance of coronary perfusion.
Very nice.
It's all right.
Yes.
Now it's okay. That's good.
Okay.
I think that's fine. Okay.
You're trying to get bicuspid, Dr.
Yeah. Okay. Good. Let's have the valve, please.
Okay.
Okay. Let's.
Okay. PA, please. PA.
We can see the chunk of calcium, nicely and geographically. I don't know if you can appreciate that. It's really good to have this kind of cerebral protection nowadays. Or you will tell me there's no evidence enough.
Scary calcium.
I'll take the sheet out.
We have really retrieved in every case quite big number of pieces of calcium.
Screen, please.
Yeah, it's on.
Dr. Salim, small patients, thick LV, huge gradient is 118. Are you scared, and patient already in hemodynamic, are you scared of suicidal LV after deploying or relieving that much of pressure inside the LV?
I do, but I think, at this stage after ballooning, I mean, two balloons at least, I think we're pretty much on the safer side. But I do definitely, keep it in mind.
Nice.
So we can see.
Keep in mind that also she's, waited for 5 years. She was, TAVI was indicated, or surgical was indicated 5 years ago. She refused it.
Yeah, I have that.
Okay. Yeah.
I have that.
My always fear is in a very small patient, you are unleashing the beast.
LAO, please.
Inside the
LAO
LV.
14.
There is a great pressure inside, and you are just letting it go.
What reassures against the suicidal is the subvalvular. LVOT is very wide, larger than the annulus itself. So it's reassured that the suicidal is
very good point.
or relatively low in this patient.
Which was seen by the CT scan measurement, yes.
Ahmed, we can see Dr. Ahmed is trying to align.
Yes.
Screen, please. Yes. Yeah, and as you can see here, the head marker is toward the outer curvature of
The right
aorta,
side, yeah.
on the right hand side. So we'll just cross the arch, and then we will check again. Yeah.
Going nicely. I don't have a lot of resistance, actually. We have to be aware about the orthopathy that those patients usually have.
Very nice.
Yeah. We'll stop here and go back to the cusp overlap view.
Ario.
You make it look easy, Dr. Arif, yet I'm sure it's difficult there. Yet I think, to be honest, with the new one, the flex, it will be even easier.
More easy. Yeah, I agree. Okay, show the wire, please, the LV. To the apex, please. Okay, it's fine. Show the LV. Can you show me, please, this? Read the table, please. Show the apex, please. Okay, that's fine. Okay. So we'll try to cross.
Sir Arif, is the aortic pressure in our screen here is accurate? Or
Okay, we cross. Yeah.
Because it's the patient has
I had
hypertension.
some resistance.
Yeah.
Push the wire.
Sorry, Ahmed, you were saying.
Take a little bit out. We need to adjust the head marker in the middle part of the pigtail. So I'll push the wire a little bit and take
Just a little bit. Okay.
Yeah, take the valve a little bit up.
1 second, please.
Pressure.
We are good here. We are good here.
Should be okay.
We can take a shot here, please.
Yes.
Ahmed, I'm
Can
questioning
you show me the LV, please? LV. Okay, this is good. Okay. Let's take a shot.
Perfect.
Okay. It will down slope a little bit. Let's start releasing, please.
So you need pacing now?
Dr. Arif, you will not comment much about the height because of the hemodynamic status of the patient, so we will let you deal
It's
with
okay.
this.
It's stable. Yeah. Let's start, please. And just there a bit the first part. One cell. Yeah.
This is diving for us.
Okay, stop, please. Stop, please. Just wait a little bit. Save that one, please. Okay, it's opening nicely. We need to go in a little bit.
A little bit, yes.
Okay. Now start pacing, please.
Okay, just a moment.
120. Start pacing at 120. The blood pressure is already low.
I don't-
So
Yeah.
actually, we don't.
Do you want to pace?
Yeah.
Let's start. Continue, please, slowly.
You want space?
the systolic blood pressure is less than 50. You don't need to pace.
Yes.
Yeah. No, it's 120. We did not do much, actually.
You might be a bit high, Dr. Arif.
I think it's okay.
Okay.
We can take one shot
Let's
here.
take. Yeah.
You want to
Ready?
pull the wire a bit?
Maybe increasing the rate is more, maybe 140, 160 to make it more
I
stable.
think we are okay.
I think we are okay here. Right?
I think we're okay.
I would, yeah.
Slowly. Pull the wire a bit, just to.
It will dive.
It's
Fine. This is fine.
It's thinking. It's nicely.
It's fine. We are at this. Okay. Yeah. Now, please at 120.
Okay, I'm pacing now.
No, it's dived in.
Okay, it's dived a bit, so.
Yeah, expected actually.
Yep.
I think we're okay. Okay.
Stop now, please. Yeah. Inject.
I think we are quite fine.
Let's go to LAO, please. Let's go to the LAO.
Yeah, I don't think we can control here with this aorta and everything.
Let's inject, please. Inject, please.
Okay.
I think it's fine. What do you think?
What do you think, guys, in the panel?
It looks a little bit deep, but the left side, when the left towards the left corner, don't worry about it, because it will correct itself. It will go up, but the other side will go down.
Right,
so it maybe is reducing the non-coronary side
Let's go overlap, please.
to make the alignment is better.
It's a bit shifty. We could go a bit higher.
Can we take another shot here, so just to make sure?
I think we are.
He's retrieving, huh? No?
Yes.
No, let's.
You see, we are just like 3,
Yeah, it looks
4
deep.
meters below.
It is deeper than before, definitely.
Let's
Take your time.
And usually don't move the wire, just keep it at the apex to stabilize and base from the beginning at 140 and keep it maintained at same level.
That's
Maybe
fine.
this
That's
is
fine.
better than...
Okay, so
Increasing to
this is okay. Here is okay now again.
Increase it to 140.
Yes. Let's go with 140 pacing, please, and open up.
From the start.
140 pacing, please.
With that much of LV pressure, would you, Dr. Faisal,
Yes,
would you go just with the 140 pacing, or would you try to obliterate?
What usually,
High, it's
in
too
that
high.
case,
Recapture,
we
please.
prefer that to start
Stop
pacing
pacing,
from the
please.
beginning.
Stop pacing,
And
please.
maybe this make the things
More.
more, he didn't space at all. I
can
think
change the angle a little
Recapture,
bit.
please, more.
stability
Recapture
there.
more, please.
What, Dr. Magheri, you have something in your
For me, it's just maintaining it.
Pull the wire a bit, gentle.
right?
The maintaining 140, 160, the pressure
that's
is
fine.
okay. Percuse and the
Push the wire a bit. Push the wire a bit for
instability of
pacing.
the rhythm is eliminated.
Okay.
What do you do, Dr. Adel?
Okay, that's enough.
Let's
What do you
start 140.
I use balloon
angle to
expandable
140, please.
almost solely, so.
Nice.
Yes, yeah.
You base at 180 and that's it. Yeah. Till you release.
Release.
So, may I comment?
Dr. Wael, yes.
So very important when you go to any view, for example, the cusp overlap or the LAO, to make sure that you are below the annulus, you have to eliminate the parallax before you decide 100% if you are deep or low. Like in couple of injection, just, like the last two, it seemed to be there is parallax. When you go from the area, from the cusp overlap to the LAO view, you will figure out that you really was deep while in the cusp overlap, because you did not eliminate the parallax. It seemed to be shallow. So instead of wasting a lot of contrast, eliminate the parallax, do your injection. It will give you the precision. And I don't know, the wire is like, I don't know if the LV is large, but the wire go back and forth, and I never used it before, and I would ask Arif about the stiffness. How do you feel? Is it stiff comparing to the Confida and the other wires, or no?
Okay.
Yeah.
Go back to the cusp overlap.
A bit deep.
He commented it's same as Safari. This is what he said when we asked about the stiffness.
Let him concentrate.
It should be okay.
Okay. Go, please.
شوية high. Very high, but I would deploy low, to be honest.
Slowly.
Yeah.
Slowly. Maybe. Okay.
This is very constrained.
Yes.
Yeah.
Not off.
Okay.
Go back.
Let's take a shot.
Go back to the other angle.
No, very constrained.
I think the position is
This
good,
is, I
but
think,
the
unfolding.
valve is folded. You can correct it with the balloon after the release.
Watch out your device.
Pacing, go.
It's
Pace,
unfolded.
please.
Just a moment.
180. Let's go. Okay, let's go.
It's already released.
Finished?
It's unfolded here. Yeah.
All right.
You're almost gonna release now.
Please, stop pacing, please.
Yeah, you can release.
Okay.
There's no way to.
Can you move from the catheter, please? Can you move from the guiding catheter, please? No, just move a little bit. PA. Move a little
Please,
bit. Okay.
please don't release. The recapture. Recapture. This is unfolded prosthesis.
This is unfolded valve, yeah.
Okay, let's recapture, please.
Yes, that's better. That's better.
Yes, it's opened a bit, but still it's unfolded. The device was
In the
unfolded.
other view, you cannot see the circle.
Yeah,
But
I think you need to take the device out for reloading.
Yeah. The other thing is, I think the patient did not have a lot of hemodynamic stability, so.
keep the wire in, please.
Very tough case,
Yeah.
Dr. Arif.
Yeah, actually, it was even a lot of tension. I couldn't get the valve easily out even. I had to use some force. Okay, now the question is whether to go with a new valve or use it again and try to deploy
No,
it
you
again.
can use it because the folding, you can correct to the balloon. Once your position is good, the balloon can correct the folding. Folding is just functional.
We'll see. We'll try one more time.
I think if you look at the device, guys, under Cine,
Unless it's
I think it distorted. I think you need to take it out and reload it or use another one. It's clear. Don't listen to Dr. Magheri.
There might be some kind of distortion in the device.
That's very friendly.
Be on the safer side.
The audience.
Yeah, let's not take the risk. Once.
Go PA, please. Just a moment to get
Wire, yeah, don't use the wire, please.
Also, Dr. Arif, in such a case, I think load deployment is not really a bad thing, to be honest. It's going to be very difficult to control.
I think there will be not easy to go the high. He will land up with a pacemaker for sure. I don't think that's going to be, and little bit down is for him safer for this gentleman rather than trying to have that optimum or perfect positioning. As we have seen, it is really a little bit challenging.
Yes.
So better to bring the patient safe. Wait a bit, please. Let them finish the preparation. Okay.
I think the only downside of oversizing Ahmed Shihri is because now we are sizing to the supraannular and we are deploying in the annulus, and you might have some paravalvular leak. What do you think about this?
Let's go.
First,
no, we are sizing to the annulus, not to the supraannulus. We are sizing here in
your perimeter is 80, right?
Yeah, 78. Yes.
76.
You're 10% oversized, 12% oversized maybe.
29.
With the 29. Okay.
So you don't size to the supraannular or to the annular or to the LV2, you size to the patient. So you take all the numbers that you have and then you get into a decent size that it fits the patient rather than this. So you don't take one numbers for granted.
Very nice take, Ahmed.
What we are doing.
So you are recramping the valve, Dr. Arif?
No, we are opening a new valve.
Okay.
That's better.
That's good.
We have some luxury here, so
more reassuring.
I will not take
the operator to have a new device.
So question, who would use a valve that's been out of the patient again? Would you use a valve that you pulled from the patient and you're going to put it back to the patient?
Yes, you can use it. But make sure that the loading is appropriate.
Right.
Maybe there is a twist in the valve, so it's giving it, if the tissue is not damaged, then you can, it can be used as long as
you can do a very good dry Cine, make sure everything is okay inside. If you see any change in the morphology of the valve, I will take it out.
Dr. Ahmed.
It's a new one.
I feel that something happening between the two attempts to deploy. You know, the first deployment was relatively okay, and then when they, recapture and then try to deploy it again, it came. So I would take it back and readjust it or actually change it with a new valve.
So I think the 29 is big for this functional bicuspid aortic valve. If I'm doing this case, I will inject the dye while the 20 balloon is inflated. If there is no leak across the balloon, I will consider the annulus 20, and then I will choose 26 device. That's why the device is constrained. and in my opinion, it will behave again. When he starts to release, the device will behave again, it will be constrained. So I think if you inject while the 20 balloon is inflated and there is no leak, you should take a 26 device. 29 is big. So this is a well-described method, and I will go for that.
The only thing though,
the point is well taken, but I think when the first time we deployed the device, it went nicely and it was opening nicely. So that doesn't maybe convince me that we should go with the less size, but certainly to be considered. I mean, 20 balloon also can be sealed, but doesn't mean that we have to go with the 26 all the time. Most of those bicuspid valve, they get no leakage, but doesn't mean that we should not rely on that one in the bicuspid valve, according to my humble opinion.
Patient is very hemodynamically stable. We are waiting for your action, Dr. Arif.
Professor Gofi,
thank you very much.
Thank you.
So we can go through the deployment of the Sentinel during reloading this valve. Can you go please? We have a very
just for the sizing, the group did the sizing very well. They showed the shape. I think for this you would size in the annulus. Dr. Kashkari's point is well taken when you have the taper type. But I think now it is time to think about maybe aggressive pre-dilatation with a bigger balloon. And I think that's the time. If you took the valve out, I would definitely do that. The last point, it would be very, because for me, I didn't see that there's a bad, definitely the valve was constrained, but before you take it from the body, you could even assess your alignment just to see if your valve has an issue before even you take it from the body, if you decided to deploy it a third time.
Very nice point. I think the first deployment was actually, to be honest, in the LVOT, and the LVOT, your LVOT is verging, so it was not a bad deployment, to be honest, in the beginning. But let's see what we can do now. Very interesting case, Dr. Arif.
Thank you. Let's hope we get the patient safe out of this room. That's the most important point. I mean, we are not going to seek a perfect ideal positioning after all what we have gone through. So we have to keep this in mind that we should really try to bring this patient safe out. That's the most important thing. And not to take any chance. I mean, we could do a lot of attempts by checking, retrying, but since we had the opportunity to get a new valve and we had really struggled by advancing, and this is a lot of calcium there, might have damaged this device while advancing. I didn't want to take this risk at this stage.
And for the idea of re-dilating with a bigger balloon, the RAFI, actually the fused part of the RAFI is 12.2 millimeters. So a bigger balloon can help, but I don't think the value of a bigger balloon will not be that much.
The aim was not to open the RAFI, you know. The aim is we opened and there was no waste. I mean, twice we did, there was no waste.
Dr. Bilghayth.
And the other thing,
I think the balloon size was very good. The 20 balloon, we were very satisfied with that diameter, to be honest with you.
Dr. Bilghayth, with the new flex, probably, hopefully, that we will not use more lender twist for the LV because now the valve more will be sitting almost horizontal. What do you think? This would help here.
I think we were reading from the American colleague who put their cases with the flex type of valve, and they were so happy with it. And I seen it in the exhibition yesterday. One of my concern with the 34, because 34, whatever you do, you will have some diving down. And I think the flex type will even solve that problem with heavily calcified, especially in the higher size like 34 with the self-expandable. And they made some changes, even the cone, they increased it about 3 millimeters more or 4.
Length, yes.
Yeah, the
for
length.
Flexibility.
For
But
flexibility.
the FX is, delivery is meant for the accurate positioning and the stability of the delivery.
That's what we want.
Remove the
stability.
backbone, one of the wires.
Can
so
we
it
pace
more.
please by 80? Keep acing. Okay, let's push this first.
Heart rate and blood pressure.
Yeah, let's go.
Can I remove the sheet?
You're going with the second valve, Dr. Arif?
Yes, sir.
We don't.
Good luck.
Is it a new valve, or did you find the valve damaged, or same valve?
We have to check afterwards. I can't tell, frankly said now. We are just focused on the new valve, but we will definitely look at it. If there is anything, we'll let you know.
Very good. Very good.
Yes.
Yeah.
No, Dr. Arif will say pacing, and I will. You keep it 180. 180 to all.
Okay.
Yeah. So you are going with another 29, right?
Yes, sir.
You guys did the valve check and everything, right?
Yes.
Right. Yeah, just now.
I can show you.
Okay, sorry, I was talking here. Yes, perfect. Thank you.
New valve.
Nice.
Okay. Push to the line.
Got it. Really.
Elio, please. Elio.
It's very clear.
Down. Move the table, please. Yes, move the table.
So the cap is the outer curvature. Very nice. You still maintain.
Yes, that's it. Okay.
That's very good. Go ahead.
No. Push the wire, please. Push the wire, please. Okay.
Let's go to the other view, please. Cusp overlap view.
The pigtail, yeah, I think. No, it's in position. The pigtail is in position. Just a lot of tension there. Okay. Right. So,
I think we need to change the view a little bit because the shaft of the valve is obliterating the view a little bit. So if we reduce the caudal a little bit,
advance the wire a bit.
Are you happy with the placement of the pigtail, Dr. Arif?
I will advance 1 second. I don't want to change anything now. We are good here. We crossed nicely.
Yes.
Nice.
Okay.
Okay. Yes.
So we can start here actually, but pull the wire. Yeah, pigtail. That's it. That's good. I think we went through that.
I will just start here.
Okay, let's take a shot, please. Make sure. We are a bit high now with the pigtail. It's not.
I think you're not bad here.
Okay.
No, it's good.
All right.
Yeah.
Fine.
If you start here, the valve will dive a little bit down.
This nun is replaced by calcium.
You need
so.
pacing now?
Okay. Can we start? Yeah.
Yeah. Maybe try even pacing from the beginning here in this case.
Yes,
Yeah,
can we
stop. Wait. Yeah. We can go with 140, please.
140?
Yeah.
Keep a pressure as well, forward pressure.
We don't want too much deep still. It's not, it will dive, it's diving already.
No, it's okay. Maintain the wire just at the apex, it will stabilize.
Yeah.
So far, so good.
So,
No pushing.
Yeah. Wait, just let it, it's too deep now. Yes? Can we push the wire a bit?
Yeah, I put it in the apex.
That's okay.
Yeah.
Now. Go.
Yeah. Some dye to see your progress.
Okay. Stop.
Injection. You're good. You're good.
I'm putting some tension to that.
You're supposed to be good.
That's good.
Go ahead. Open the valve.
Let's go to open.
Go to 80,
Open.
then you can take the co-planar view.
Yeah. Let's open the valve. a
Okay,
bit just
I
so operation
will
breathe.
off pacing.
Stop pacing, please. Go to Leo. Go to Leo, please.
That pressure is so. Yes. And now it's recovering.
Pressure is down.
That's fine. That's fine.
Okay. Inject. Oh, we have to deploy, please. Okay.
Yes.
Pace, please. Pace, please. Go. Open the valve. Pace. Open.
Slowly. Good.
Yes.
Thank you.
Okay. Stop.
Good.
Stop pacing, please. We need little help, please. Some
Yes.
support, please.
Yes. Now you can all take a breath in the room. And we can take a breath as well. We are holding our breath here for you.
Thank you. I need your spray.
Please.
I need to get out the system.
Okay.
Screen.
1 second. Slowly, gently, please.
Yeah, watch out the nose cone.
Push the wire. Push the wire first. Push the wire.
Just 1 minute. 1 minute.
Push the wire, please. There's a lot of tension there.
Yeah, the nose
Take your
cone.
time. Yeah.
That's good.
Center. That's good. Okay. Very good. Excellent. Save that one, please. Thank you.
Yalla, close.
Pressure is coming back.
Yes.
Excellent.
Alhamdulillah.
Yes.
قاعدين ندعي لك ترى مو انت بس اللي
That's
تدعي.
like what he said.
دعاء الوالدين دعاء الوالدين. Okay.
Very good.
1 second, please. All right. Let's now
Position نفس الأول.
go back.
Yeah, I think.
Let's go back with the pigtail. The pigtail little
I
back.
would have accepted the first one, I think.
Okay.
Yeah, and bear in mind that the calcium is lower than the pigtail. The pigtail
Yes,
is a little
yes,
bit
yes.
higher, and that's why يعني adjusting to
take
the
the
calcium is
pressure,
much
connect
more
the pressure, please.
Totally,
much more accurate than adjusting to the pigtail.
Okay.
Yeah.
Can you connect the pressure?
Sometimes coplanar does not work because the non-coronary is replaced completely by calcium.
All right. So
Yes,
now we need to
absolutely.
take the pigtail, take a wire, the pigtail out.
The pigtail.
Can we take one shot at first? And
Yeah. From where?
We'll equalize, we have to.
Yeah, that's, I think it's very, very nice.
We may need to pause, but
Maybe
we'll see.
just a little bit.
Okay.
Yes.
No, but the big tail level is below the valve itself, so that's why there is AI.
Yes, big tail نازلة مرة.
Take the big tail out, then take a proper angio.
Because you are
Yeah.
below the leaflet now, almost.
Absolutely. Ahmed wanted immediately
Yes.
to be happy
Yeah.
to see something. But we remove it and then
Let's-
that doesn't reflect the exact
Let's put our.
existing AI.
Give me a wire. please.
Dr. Wael here is suggesting we go caudal just to remove the parallax and see the valve as well. The constraint.
No,
Yeah,
but
we'll do after we
good
get
thing
out
in
the
this
big tail.
wire, they can take the hemodynamics.
Give me a regular
Just
wire.
ease the wire back below in the LVOT is better than the apex. Then take the hemodynamics.
We can connect, just let me remove this.
But we need to.
Yeah, I'll take it from you.
Yeah, please. Then you can connect the hemodynamic to the wire. That's the beauty of this new technology, frankly, sir. Yes. Go back.
Dr. Arif is an early adopter of every technology that comes to the field. Very nice to see
Wallah, we
Alqassimi. To see
Thank
Alqassimi
you, sir.
always adopting a new technology. I
I mean,
that is-
our field is really evolving and we have to go the world, you know, along.
Arif,
we
this
cannot
is
wait
Fahad.
behind.
Nice case. Arif, if you come pull the savvy wire a little bit to the
Yeah.
LVOT, so you will
Yeah,
check
we'll
the
do for
gradient. Okay.
We
yes,
will-
for equalization. Yes.
Here, we will do that.
Yeah.
Thank you, sir.
Little bit more.
Okay, are we, go back a little bit.
Still
to
we
the
are in the
pigtail.
LB. Yeah. So yes, I'll flush. But give me a flush, please.
You can see.
بدأت.
Here's
We'll still.
we have to put it in the supraannular.
Yeah,
You might need to post it, I don't know.
Now.
It's less than before.
we may need to, but we will
Yeah.
see. We will give it injection and see what's happening. We'll do an echo.
Yeah.
Pressure.
Here, here
Watch,
now-
watch out the wire.
No, no, we are
We are on
deliberately
purpose
taking
with
out
this,
the wire
the-
to realign the pressure from the
The
wire.
sensor is proximal to that curve, so we wanted to have equalization of the aorta.
Yeah.
Same
So
like
just pull it back to that.
Equalize, please, like the, yeah, absolutely.
See now,
Oh,
we
very
can have
nice.
that
Better
equalization.
now. It's almost
So
equivalent.
here we are equalizing the pressure coming from the wire to the pressure coming from the catheter, and then we can push back
Advance
again,
again, go back.
the wire to the LV.
Yes.
Because the fiber optic sensor is just at that transition from the curve part of the wire to the straightened part.
Who is the
Okay,
main concern
so-
is the wide pulse pressure, low diastolic pressure. Is it significant BVL or AI? Maybe can be tested in the angio.
Yeah. I think comparing to the pre-curved area, it almost looks like an X small Safari comparing to.
It looks like so.
It is an X small, but maybe we should have gone with a small one. Okay, let's take an injection here, can we?
Okay.
Are we ready?
Ready for injection?
Sorry.
We can change the angle just to adjust the, remove the parallax
Very
of the
heavy
valve.
valve.
How much is the gradient so far? 20?
Yes, almost.
Okay, yeah.
The mean of 30, we need to.
Can we inject, please?
Auto? Can we put
Priyesh, can we inject, please?
Big tail.
Okay, let's go, please.
Big tail شوية.
Yeah. Okay, it's not bad.
It's trivial, to be honest. Mildly trivial.
Reminding you, we had the same in the beginning also. Yeah, we have this calcium extending to the
and you have a wire
LVOT actually. Yeah, we have the wire. That is certainly another issue, and a lot of calcium there. It's a deep implantation also a bit. Can we see an echo, please? And then we will remove the wire and see also how it is. But I don't know.
Maybe take different view. Maybe there is a folding of the valve at one side. Maybe from the side of
we will check the other. We'll take another view.
Arif, please.
Other thing, Dr. Arif, I would do an echo, to be honest. There might be some LVOT.
We are doing immediately. Oh, yeah.
Very nice, Al-Magheri. Very nice catch, Dr. Al-Magheri.
So we need to post-dilate for sure here.
23 balloons.
Constrained. Very nice comment, Dr. Al-Magheri.
So it's real.
Very nice.
The bicuspid.
Okay, let's take a 23 maybe.
Yes.
Can we have a 23 balloon, please?
What size balloon you would use?
23.
Take the waist of the valve itself is 23, so to improve the waist at the level of the valve itself, the supraannular valve.
So let's also, it's not elliptical bicuspid, but if it's an elliptical bicuspid, maybe, and some LVOT calcium, maybe we have to think really carefully about the size of the balloon post-dilating, even though
we still will stay inside the frame.
We are a little bit conservative. The mean diameter for the aorta is 24, so we didn't exceed that. On the contrary, we will take
the echo, it shows something like grade 1 to 2 maximum. So it doesn't look to be a massive AR. If we can just focus the camera on the echo room, that will be possible. Let's go.
23. What size are you going to use, Dr. Arif?
23.
23 should be fine. Push the wire, please. Yeah. Nicely going down. Okay, here should be fine.
No,
I think here is good. Let's ready for pacing, please.
Yeah, 180.
Yes, please.
180, we're ready.
Okay,
I'm ready for pacing. Just
1 second. Pacing.
You mean down with the balloon?
The balloon.
It's okay. It's good.
Looks fine.
The valve itself is down. Anyway,
It's not
the lower part of the
And if it's pulled the valve a bit higher, it wouldn't be a problem. There is a good
pacing, please. Are you pacing?
Okay. No, I'm now.
Inflate the balloon away
Okay.
from the LVOT.
1 second.
Just a moment.
180, yeah?
The pressure is not.
Touch the waist, but
The pressure is not down
it
yet.
should be down a little bit.
We need
that's
we need the
Dr.
pressure down.
Arif, there was a comment.
200. 1 second, please. Just,
Take
yes,
your
go
time.
ahead, please.
You want to push the balloon a bit?
Just a moment. 200, please.
خلاص.
Okay. We're ready. 200.
No, the pressure. We
Okay.
need to pace, please.
I'm
1
pacing
second.
now.
It's not pacing.
No,
Now
I'm
it's
pacing.
pacing. Okay. Let's go, please.
أيوة.
It's good.
I have a strong man next to me, Dr. Ahmed.
Keep it there.
More than this, you have to come by yourself. I think you can do this compete with
Okay,
Dr.
pacing
Ahmed.
off.
Okay, stop pacing, please.
More than this, you have to go inside and fix things with your hand.
I don't think it's going to go
No,
away.
it's good.
I didn't need that one, but we could.
But
it's
it's
better.
expanded
I think
nicely.
it's better.
Much better.
We cannot, I think that's not bad at all, really. I'll show you. Look at that. The constraint for sure, we are not going to achieve what we are achieving in the tricuspid valve for sure. This is a heavily calcified bicuspid, we have to bear that in mind. So, and that the echo showed me also, even the AR was not significant, frankly said. This is maximum 2, actually 1 to 2 maximum.
And this is even before.
And that was before the post-dilatation, as Dr. Ahmed is saying. So let's see, we will give one more little time and then
Dr. Faisal, this
pull the
valve
wire a
sealed
bit, please.
very
Like
well,
little
even
bit.
though it was actually
back the wire,
underexpanded that much.
Too much.
That's that much calcium he have. That was a bit scary, don't you think?
of course.
Okay.
All the time. This is
Can
the most
we-
important issue that
Let me see.
thinking about.
The echo.
The most important things that we are thinking about, whether we are bleeding
Yeah, it's better. It's
and
better.
all the precautions. I
Now-
was anticipating all the complication.
Let's do an angio.
It is anticipating that could be happen, and he's
No need.
working to solve one by one.
We'll take it out.
I think they are prepared.
Take it out,
for
please.
Totally, yeah.
I can tell you from echo, it is 1 now. It's not more. It's less than before the post-dilatation. I can see it. It's maximum 1.
Yeah.
So we will do another angio.
And
And
as
this
you-
is with the wire inside. I mean, we have to remove the wire also.
Just
And
after,
then,
and then we take
but let's make sure first of all.
Let's take our
Echo people around.
You know, saying we will prepare with the 23 balloon because we also anticipated this before.
You know, at this stage, maybe removing the wire to give us a good insight if it's not just, you know, intravalvular regurg.
Problem is they- just
So,
want to
because
make sure
you
there's
already,
nothing-
you already post-dilate with very good
Remove the wire.
size balloon, you know,
But we are
further
using-
post-dilating.
If you are
is
all
not a good
happy,
idea.
I'll take it with the
let's
pigtail.
take the
Give me a
pigtail.
pigtail.
Okay, we will take it out.
Yeah, you can
we could take
recross
it out.
if you want
Yeah.
easily.
Shehri, you have a point?
Absolutely, absolutely.
Sorry?
If the,
Shehri.
yeah. The peak to peak gradient is 25. I think it's
لا ما انت
better.
خلاص.
Is it? Because I saw that the 29. So I think it's better just to take the wire out, put a pigtail, take
Yeah.
pictures, find out a mean gradient. What's the mean gradient? I know it's sad to get a double digit on supraannular, but this is bicuspid aortic valve to start with.
And they started with a gradient
Oh,
of
with 100.
But we can get the mean gradient because the wire is in still.
Mean gradient was 100 and peak when one of them was 220. I don't know.
Give me live.
I have not
Give me
seen this
live.
number before.
You want to go up.
Dr. Arif,
I
how
don't
is
know
the
how
rhythm?
many-
You can take gradient to have
The what?
inside, yeah.
The rhythm.
It's the same as we started.
The rhythm is
Same.
sinus rhythm.
So that's a
There is
good,
no wide complex, nothing.
very,
So far,
very
it's the same.
satisfying. Right bundle, left
If we
axis.
take an image and there is no regurg or paravalvular,
we'll do
it will be
echoes.
okay because the gradient will go with time as the valve expand. But the concern is the diastolic pressure is only 30. Is it because of the severe atherosclerosis or significant aortic regurg?
Okay, I'll take the wire out.
Okay. Equalize.
It's
That's
okay.
it. So it's out. Okay. All right. That's it. They wanted to have a pigtail in, but
Yeah, the pigtail is there.
no, to inside.
The wire is outside.
But anyway, we can take a shot now here.
From 100 to
So
29.
already, this is,
Yeah.
there's some,
Are we ready?
Yeah.
Ready, Prish? Can we take a shot?
Maybe you can take a panoramic or a spin image to see the valve from multiple sides.
Let's go from the other side. Yeah, we will do from that side also. Go to LAO, please.
I would call it trivial, to be honest. It's a clearing with every point, with every beat. So one mild to
Inject,
trivial.
please.
It's well expanded here.
I mean,
Here
I
looks
will try to
absolutely
take the
fine.
parallax off before I inject.
Ready?
Good.
They're still.
Here it's mild at least.
It's a paravalvular most probably. Can I see the
I would
echo
accept
again,
this.
please?
70.
yes, it should reduce over
They
time.
started at pressure of Mio, Shay.
Very hostile anatomy.
Probably you can still take another inflation with the balloon to improve it more.
So post dilate further.
Post dilate further.
If your inner diameter is 23, can you post dilate with a bigger balloon? Are you going to, are you risking?
Frankly said, with all this calcium there,
So what do you, Dr.
going to
if you want
challenge
to
my,
answer
you
this,
know,
for
my
post-dilatation
luck
of
today.
self-expandable valve, what's the maximum size for the you could use for such a patient?
I think
Can we take a
regarding this
image
case,
here on the
they
echo,
did a
please?
good
Can we show
size
the echo?
and they use almost 23, which is very reasonable for this measurement. You
Come to
get
Ario,
a perimeter
please.
of 76. And the minimum, I think, diameter was in the 20s.
So
I
the
have to be very careful here. If you have to do it, you have to anticipate what you're going to achieve before you do
The
it.
29 is 1 millimeter below the lowest end of the valve. the waist of the valve is almost like a 23, 24. And they post dilate to that limit, otherwise you can injure the leaflet insertion, which is where the leaflet is inserted.
Yeah, that's my point. We need to know more about the echo.
Yeah.
If the echo is
I can show you the
acceptable-
echo. It's not showing much actually. I'm taking, can we have the screen on the image? Yeah, you can see that now. Here you have the echo.
You can see it. In the
One second.
valvular assessment.
Put the window on the aorta, please. Move the window.
العتيبي واقف يعني I think he has a concern.
Yeah, I think great efforts, great work, but I still combination of bicuspid remaining gradient of 25, significant AI, I will post dilate, and knowing that the anchoring mechanism bicuspid might not be the annulus, might be the Rafi. So, and it might cause recoil. And the only way to test it in this case is to go for 24 post dilatation. I will go for 24 post dilatation. If it recoils, then I call it a day. But otherwise, to sort out all these, to sort out the gradient, systolic gradient, the AI, to longevity of the valve, and to reduce the structural valve degeneration, you have to post dilate, I think.
Are you open to this idea, Dr. Arif? Did you hear Dr. Al-Ataibi?
I hear that, but I'm a little bit thinking it is really pushing the edge. You know, we are accepting this result, and we know that this will come a little bit down after. This is self-expandable one. I know that is not an ideal result. We have to. We said this from the beginning.
Yeah.
But
he's not
I
an
may
ideal
risk
patient.
to really to push ourselves to the edge. You know. And I think with this patient will be really good with some medical therapy, and we will watch him, and we can still bring him if needed.
We need to see that.
What's the hemodynamics? Systolic, diastolic?
خلي يغير الكاميرا يدفع شوي.
One of the other thing is to use a true non-compliant balloon. If you are afraid of oversizing and you want to go with the annulus, maximum diameter or the mean diameter, so 23 Atlas gold or true balloon, a good inflation, I think it will do the work. Bear in your mind, your valve now is deep. The valve with, the part of the valve with the most radial force is the base of the valve, which is already down. Now your area of the constraint, or where is the raphe, is the area opposing to the weakest part of the valve. So you really have to use a true non-compliant balloon, and I will assure you it will do the work, and just go 23, 24.
We can, I mean, this is really something that can be done either way. Frankly said, from my perspective, I'm happy with this, and I will wait and see how he will be in the evening and tomorrow morning.
Arif, what is the echo assessment? Is it like mild to moderate?
No, it's mild actually. It's not a moderate. It's mild to moderate. 1 to 2 maximum, as I said. It came a little bit less than before. So I'm happy with the echo, frankly said. This is not the echo that makes me really urge and go in again and
the mean gradient, the baseline mean gradient in this patient was very high.
Yes.
Exactly. I mean, look at this. You can see the image. I mean, the echo is really not frightening. I wouldn't rely only on this angiographic. I can show you. This is not an AI of more than one. So I wouldn't go more. You can see the image. I mean, you can
but
see
if the patient is hemodynamically stable, that means the things are okay.
Pressure is 100. Patient's 100 almost, systolic and everything. So I wouldn't do, frankly said. I will finish here.
So I do agree with you, Dr. Arif. Since, I mean, the echo didn't show any severe PVL, it's only mild to moderate. And the patient lived on 100 gradient for many years. So I think, 25 is not a bad idea to leave it at this. Because, you're risking it rather than, helping by further post-dilation. You may cause a rupture and...
Absolutely. You've seen how much we struggled to cross with the balloon, the calcium chunk, twice the balloon, the valve did not open, and then going with non-compliant again against all this has to go somewhere. this calcium will go somewhere, and I don't want to take that risk for this a little bit of improvement of 5. I mean, what am I going to aim? How much I'm going to achieve after this? What do you expect?
Dr.
I mean,
Arif,
to have it zero
these
AI.
patients.
This is, yeah. From my point of view, I'm done here. So thank you very much for your comments. But I think I respect all your comments. It was great help for us, frankly said, in this particular case. But from here, if you are standing in my place, you will feel what I feel, that I think we've done enough for this gentleman.
Totally agree with you, and you are more capable than this great effort by you and your team. You managed a very difficult case with a very hostile anatomy. I guess when life gives you a lemon, you make a lemonade, and this is what you're going to get, and you have to set your expectation, depends on the case itself, and this is a very challenging case. And this is an acceptable result, especially for somebody who's been standing there and doing his best to get those results for a very sick patient in hemodynamic support. Great effort, great work by all of you in the team, and we are very proud of you, to be honest, as an early adopter of technology and very excellent doctors there. Thank you very much, Dr. Arif.
Thank you. Thank you very much. Thank you very much. Have a good day.